Alright, so today we're going to talk about the etiology, diagnosis, and treatment of impacted teeth. We're going to focus mainly on canine and molar impactions. So I'm going to go ahead and start us off today with the etiology of impacted canines, which I myself had one. So it's kind of an interesting topic to me. So as you can see here, we have a nice little pan of impacted teeth. Like I said before, I had a unilateral impaction on my right side, number 6. It was horizontally placed over my central incisor, and when they did the elective surgery and went through the palatal aspect, pulled it down, the tooth itself rotated, and now the lingual aspect of my canine is on the facial, and on the facial side of my canine is now palatally. And for a small fee, you can have a look-see. Just about $5, I'll let you take a peek at my canine. So we'll continue on now with facts and such about impacted canines. So some interesting facts that you may or may not know about impacted canines. They are obviously second to third molars for frequency of impaction. 2 to 3% of the population actually have impacted canines. With that, it is twice as common to see in females as in males. And then the incidence in the maxillary arch is more than 2 times greater than that of the mandibular arch. So if you do see these, a lot of times they're going to be in the maxilla, and oftentimes again in females. And then of that population of people with impacted canines, 8% are bilateral and the remaining percent are unilateral. So most likely you're going to see just a unilateral impaction. 1/3 are maxillary impactions are labially impacted, and then 2/3 are palatally impacted. And next we have the etiology of impacted canines. There are studies that show that 85% actually have sufficient space for eruption on palatal impacted canines, and only 17% have sufficient room on the arch for labially impacted canines. Thus, arch length is thought to be one of the primary factors for labially impacted canines. And according to one of the research articles that I read with Duell, he stated that maxillary canines have the longest period of development, so that kind of is one of the main reasons why they figure out that they do have impactions, as well as the longest and most tortuous course to travel from the point of formation and then lateral to the piriform fossa until they reach their final destination in the arch. And then other philosophies of thought include localized systemic and genetic etiologies. And as you can see on this slide, it's just a little chart kind of describing localized systemic and genetic possibilities. With localized etiologies, you could have just tooth size and arch discrepancies, failure of the primary canine root to resorb, prolonged retention or early loss of primary canine. Then you could have cysts or dilacerations, absence of maxillary laterals, then iatrogenic and idiopathic factors. Some of the systemic etiologies include any type of endocrine disorder or deficiency, disease, and then with genetics, which I think that's what happened with me. My parents decided they wanted to have an ugly child, so I popped out and then had some palatal impactions. But hereditary, malpose tooth germ, or presence of an alveolar cleft. And now with the two main theories of thought that I found throughout the research were the guidance theory and genetic theory. With guidance theory, it's basically stating that the canines erupt along the root of the lateral incisors, and the root is either absent or malformed, thus causing an impaction, delayed eruption, etc., etc. Pretty much just kind of basing it off of the laterals themselves as the main cause of the impaction. And then, like I said, which I think I am, genetic theory, our whole family has some messed up teeth. You would think that from Kentucky, I'm just kidding. Genetics, missing or small laterals, reciprocal relationships with other dental anomalies, and then some systemic diseases such as enamel hypoplasia and infraocclusion of primary molars, aplasia of secondary premolars, and small maxillary laterals. And continuing on with another little tidbit that I found throughout my research from Jan, buccal canine impactions are the most associated with anterior transverse deficiency and incisor impaction. So anterior transverse deficiency is more of dental and skeletal anomalies, and then again incisor impaction. And then palatal impactions are most associated with small or missing lateral incisors, and this is consistent with the guidance theory. And just kind of here on the bottom right hand, you can see that one is palatally impacted and one is buccally impacted. I actually tried to look up for some research articles about if they are bilaterally impacted. How often do you see it that both are buccally or both are palatally impacted? Or kind of like this picture down here, one buccal and one palatal impaction. Didn't find too many articles that would discuss that or had enough proof. A lot of them would look into people that have buccal and palatally impacted teeth, but they didn't conclude anything from it. I guess the results were inconclusive. So that's pretty neat. And then the next slide we're going to go to has the sequelae of impacted canines. So with the sequelae of impacted canines, basically if you just kind of let it go, like Elsa, you kind of find out what happens with the canines. So here's kind of the order of things. So one, you have labally or lingually malpositioning of the impacted tooth. So if it is impacted, you need to know which way it's facing if you're going to go after it with any type of surgery or ortho. And then you have migration of neighboring teeth and loss of arch length due to the impaction. So, I mean, teeth move constantly. So, and then you could have internal resorption of the teeth themselves, and then possibility of dentigerous cyst formation, and then external root resorption of impacted teeth, as well as the adjacent teeth. That's a kicker for people who are trying to save the teeth or going through ortho. I mean, you do have root resorption with orthodontics to begin with, but with impaction, it just makes it a little bit worse. And then continue on, infections, particularly with the partial eruption of the tooth. That's definitely not a good thing to happen, because if that's the case, then you will probably end up losing the tooth. And then finally, referred pain and combinations of any of the above. So that will wrap it up with my section. I'll show you the references here in just a second. We're going to continue on with the impactions of molars with Michael, and then kind of go through the process of diagnosing these impactions and then treatment, when to treat, when not to treat, etc. So I hope you enjoyed this movie. I'll try to throw some little tidbits on here at the very end, kind of kickers or some bloopers. But obviously, Jacob Bishop doesn't make bloopers. He is perfect in all aspects. And here again are my references. I now have to go outside and rake some leaves as my mother-in-law is yelling at me from the kitchen. So, thanks again, and enjoy the rest of the presentation. Deuces.